Welcome to another episode of Voices in Health and Wellness, where we speak with clinicians, innovators, and healthcare leaders who are challenging conventional thinking and helping shape the future of patient care. Today's guest is Dr. Thomas Buchheit, founder of Triangle Regen Medicine and Biologic Center in North Carolina. Dr. Buchheit has spent years studying regenerative medicine, platelet-rich plasma, stem cell therapies, and immune-based healing. He's also the author of Healing Joints and Nerves, a book helping patients understand why regenerative medicine replaces a genuine shift in how we are healing. So today we're going to discuss orthobiologics and why it remains misunderstood, the science behind regenerative medicine, patient education, and where this exciting field is heading. So with that, Thomas, I'd like to welcome you to the show, and thank you very much for joining me on this podcast today.
Dr. Greenland, thank you. It's a pleasure to be here, and thank you for inviting me.
You're very welcome. So perhaps we could start a little bit about you and your journey. So just tell us a little bit about your journey so far and how you've found your way into regenerative medicine.
Well, it's a great question. When I finished residency and fellowship, this field didn't exist, right? So I finished an interventional pain and spine fellowship in 1999, and I became fairly steeped in the spine world for about a decade or so. And there are some things about that I found a little bit distasteful over the years. Medication use and heavy surgery use for spine conditions. And in 2010, I had a really nice opportunity to join a research group and a clinical group at Duke. And so I ended up leaving the practice I was in and joining up with Duke, and really started a really interesting journey of not just understanding nerve injury and mechanisms of that, but also learning about how those the same mechanisms that exist in, for instance, osteoarthritis. I started looking at and focusing on not just risks of chronic pain, but resiliency. So if you have 100 people who have the same condition, what makes those who recover from pain and are resilient, what's different about them? And the answer was really the immune system. Those who have a strong immune response to injury, interestingly, are more likely to recover. And that has implications for all of us, right? It has implications for exercise. It has implications for our use of anti-inflammatory medications or steroids. And it really forms the foundation of regenerative medicine. When we studied kind of all these therapies, and it was really a really wonderful exploration.
Amazing, thank you. It always really helps to have some background and context as to the work that you currently do. So I think you've kind of already alluded to this, but what was that particular moment that convinced you there had to be a better approach than traditional pain management? I think you've given us a couple of clues, but what was that trigger for you?
The trigger was probably a paper in 2017. It came out in JAMA, Journal of American Medical Association, and it showed an association with repeated steroid injections and accelerated osteoarthritis of the knee. And that was the moment when I read that paper that I realized that we really have to change how we're practicing. Because I came from a world, and we all did, where we thought that if you have inflammation in a joint that's arthritic, if you quiet down that inflammation, the joint's going to get better, you're going to improve the pain. You might actually improve the joint longer term as well. And it turns out we weren't. It turns out we were actually making things worse, not better. So that was my kind of threshold moment. I realized we really need a new pathway and a new way of looking at this.
Thank you. So I think you mentioned that regenerative medicine is often misunderstood. So how do you define regenerative medicine, or how do you explain that concept to your patients? And what is this misunderstanding that exists out there?
Mm-hmm. I like to think broadly about regenerative medicine being the restoration of tissues and restoration of function. Some people think of it as growing new tissues, growing a new heart, a new ear, something else. That's a narrow definition. But to me, anything that restores function and restores tissue health is regenerative. And in that respect, exercise is probably one of the most regenerative therapies that we all do, right? And if you think about it, it makes a lot of sense. So, when we exercise or work out, you actually create an inflammatory process, right? And you can even biopsy a muscle afterwards and see increases in interleukin-6 and all these inflammatory cytokines. But you start a cascade of healing that ultimately will strengthen those tissues and grow those tissues. And that's why all the literature on, for instance, exercise and osteoarthritis is very clear that brisk walking is a good thing, good exercise for somebody with arthritis. So So that's, to me, that's the fundamental step, is that that immune cascade, and that really formed the basis of the book. I started working on the book about 6 or 7 years ago, and with the goal of helping people to understand how these therapies work. How does stem cells really work? How does PRP, platelet-rich plasma, really work? What is this thing called Regenokine that people are flying to Germany for? And how does it work? And we can dive into some of the research we did with that. And it was really a wonderful exercise to go through systematically. I probably reviewed over 1,000 papers in the process of writing this book, to try to distill down the science to a broad audience. It turns out that all of these therapies just work in different parts of the immune system, which is really interesting. You may have PRP that works early on, where, if you think of an injury, you have an injury and you have platelet release. Yes, you have clotting factors, but you also have growth factors that release. They recruit in neutrophils and these early white blood cells. They were then recruited in monocytes that come into the tissue, become macrophages. And if all goes well, the macrophage polarizes, right? And it starts to rebuild tissues. And you can slot in all the therapies, including stem cells, into this immune cascade, which I thought was it was a nice framework to hopefully help people understand how these treatments are working.
So in terms of your repertoire of tools in your box, as it were, what are your most treasured tools that you can offer people, or techniques, treatments, that perhaps they've not heard of before, that you can really get some leverage over their condition with?
Probably the main tool that people have heard less about is the Regenokine program. And that's, people think of it as a PRP-like process, but it's really not. It comes from blood. So you take blood out and then you let it coagulate and clot overnight. And really what you're doing is letting those blood cells and those white cells work very hard for you. And then we filter, we have a full lab, full sterile lab, full hood and everything else for processing. And you filter that and process that and then start injecting that. And that's really been a very nice therapy for people where other things have failed. Most of the people that we treat with Regenokine have had other treatments. They've had PRP, they've had stem cells, they've had prolotherapy. Those haven't worked, and so now they're coming for something else. And it's been nice. It started with Dr. Peter Whaling in Germany, and at least in the United States, we always hear about pro athletes who are flying to Germany for their treatment. A lot of times they're going to see Peter, who was my mentor and still is my mentor. I've worked with him for 7 or 8 years. And I've been using the program here in my Chapel Hill office since we opened up, and I used it for years at Duke when I was at Duke. But it really is a nice treatment when other things have not worked, and we know how it works now too. So we actually teased this apart in the lab. People always used to think of the Regenokine program is a product of what people call IRAP. Right, so interleukin-1 receptor antagonist protein. So IL-1 antagonist is a protein our bodies make to fight and shut down IL-1, to shut down IL-1. And it is powerfully analgesic, but if you study IL-1 IRAP, that protein, it only works for a short period of time in an arthritic joint. And there was some part of this therapy that we were missing, that we weren't understanding. So we took it to the lab and we dissected out the different mechanisms of it, biochemically and also in animal models. And it turns out that it's actually exosome. Most of the effect is exosome based. That is a nice story for me and for patients as well, because people talk a lot about exosomes, and we can dive into that a little bit. But the most important part about that is making sure they're safe. And if you can get exosomes and exosome therapy from your own blood, not from donor blood, you've also increased the safety of that product as well. So that was a nice research journey over several years as well.
Amazing. So I think in our last conversation, you described the paradigm shift as to what was been happening before in pain management as versus to the kind of work you're doing now. But what do you mean by paradigm shift, and how has your philosophy of medicine changed as you've been doing more of this work?
Right. To me, the paradigm shift is shifting from this concept of suppressing the immune system with corticosteroid injections, with NSAIDs, to igniting it. Really, what my interest, and I think your interest as well, right, is how do you turn on these healing mechanisms? And first, you feed the body, right? You feed the body with the polyphenols and the bioflavonoids and all these good products your bodies need to heal. And then you turn it on, and the foundation of that obviously is exercise and motion and movement. But sometimes it's not enough, right? If somebody's had a prior injury, old meniscus tear, they've got some arthritis, they've got an old ACL injury, labral tear, those mechanisms may be enough, but they may not be. And that's where I then go into employ some of the regenerative therapies as a way to reignite that healing mechanism, kind of push them along that journey. So to me, the paradigm shift is from suppression of inflammation to actually using it, harnessing it, and turning it on. And so the first thing I do using people come in the clinic is I take them off anti-inflammatories. We don't do any therapies until if they've had corticosteroid injections, until the steroids are washed out of their body, because we're trying to turn on all those mechanisms. And it's a very different approach. It also takes longer. The other paradigm shift is people have to be patient. So if they're used to going in and getting an injection, feeling better the next day or 2 days later after steroid, they have to realize that these treatments take time. And if you look at the immune cascade of how our bodies respond to injury, it makes sense, right? If it takes several days alone just to run through that cascade of platelet degranulation, neutrophil activation, and macrophage polarization, that's not a 24 to 48 hour process, right? That's a longer process. So part of that paradigm shift is turning on and igniting these healing cascades, and part of it is also patience from the patients to understand that this process takes a little bit longer than, for instance, a steroid injection.
Thank you. And so thinking about the patient journey itself, how has that evolved over time, from where you've come from before in pain medicine to what does it look like now? Give me a typical condition that you might treat and just kind of show us what the journey looks like for them.
Probably typical treatment would be somebody coming in for knee arthritis or rotator cuff tear with some, glenohumeral osteoarthritis as well. So a degenerative condition. They've had a couple of steroid injections in the past. They've probably seen a physical therapist. They're on anti-inflammatories. Maybe they're on some supplements. Maybe they're on some other stronger pain medicines. And the journey is we meet. I actually go through diet with people. I go through some of the supplements. I believe in some of them, especially omega-3s and some of the fatty acids that help resolve inflammation that our macrophages use for that process. And then we talk about how to regain that function. Everybody's different, right? Some people are trying to get back to the NBA, and some people are just trying to be able to walk their dog again. And so you have to figure out where that person is starting and what their goals are. And we can usually get there. We can usually get there with different things. The other thing we've done is with PRP is that we've started to increasingly use a lot of boosters. And those boosters may be protein concentrates with A2M. Some of them may be other things of autologous, like SuperShot that we've started to use that has autologous exosomes. It's not the Regenokine program, but it's a single injection. So all these therapies, I think, can be tailored. The other part of this process is that, we talked about the importance of immune stimulation with this, and that's been really a fantastic learning opportunity in the world of platelet-rich plasma, right? So, a lot of patients come in, they say, well, I saw this study in JAMA, or I saw this study in another journal of PRP doesn't work for knee arthritis. But if you tease out those studies, looking at the platelet doses, you can predict what studies are negative and what studies are positive. If there's a PRP and they use less than 3 billion platelets, it's going to be a negative study. And patients, I think no patient should receive a PRP with a platelet dose of less than 6 or 7 billion for a large joint. We actually, increasingly, it's been obvious that we really need to get closer to 10 billion. So what we start doing in the clinic is using that information. Say, if we want 10 billion platelets for a knee, 6 billion for a tendon, let's measure it and calculate it, make sure we get there. So we measure the person's platelet count at the beginning of the procedure not from 2 weeks ago, because it may be different from 2 weeks ago. We have them exercise before they come in to activate these mechanisms. We measure their counts, and then we ask the question, how much blood do we need to get them to 10 billion or 16 billion or 24 billion, whatever we need. And then we draw that blood because we know we're going to get a 79 to 82% yield in our process. And then we can reliably deliver the doses we need. And it really has made a big difference in outcomes. It's a longer process to do, but it's been very satisfying to do because we can deliver what we think is some of the best treatments in the country. And there are a couple clinics in the U.S. doing this now, but it does take a little extra work, so it's a little more labor intensive to do. So,
thank you. So with everything you've said about the healing processes that you can elicit using your techniques, why have we become so fixated on suppressing inflammation? Why are we not? Why is it not this more broadly accepted as an approach for achieving this sort of level of healing?
I think it's history, right? I mean, we can go back to 1899 and the synthesis of aspirin. Mm-hmm. We can go back to 1951 when the first corticosteroid injection was done for knee arthritis. That's what we grew up. That's what we all grew up with, which is that if you have pain, you put steroid on it, and it usually makes you feel better. And it's true, right? If somebody has a painful joint, a tendon, whatever it is, if you put steroid on it, it usually helps it feel better pretty quickly. And so to me, I think it's inertia and it's habit. And it's hard to change people's minds about this too, because we're also talking again from an injection where somebody can offer in their office very easily, that is going to produce pain relief very quickly, to one that's a much longer process. But that longer process is going to help longer term. And so to me, it's just history, and medicine is slow to change. It is. And the other thing is insurance companies don't cover treatments that stimulate the immune system. They cover suppression. They'll cover NSAIDs. They'll cover steroid injections. They'll cover ways to burn nerves off of joints, which I used to do and don't do anymore. And I would make an argument that burning nerves off of joints is not a good idea unless they really don't have any other options. They'll cover things that destroy nerves and suppress inflammation, but they will not cover things that stimulate. Now, I think that's going to change, right? And actually the oncologists, I think, have helped us out a little bit here, because they have opened up this world of checkpoint inhibitors and immune stimulants that can potentially cure cancer. So I think this mindset has begun to change a little bit, but that is just starting to creep into the world of orthobiologics and the care of joints and nerves. It's going to come, but I think it's going to be a few years.
Well, I guess this is a relatively new field. I mean, I know it's been around for a while, but with every new field, there comes a marketing challenge in terms of how do you get the message out there? How do you get patients to understand what it's about? Mm-hmm. What's your kind of approach to this? How do you, for want of a better expression, sell this?
Yes. That was a challenge. That was a challenge for me, and remains a challenge, because I can speak at all kinds of academic conferences and write papers and everything else, but patients don't see and hear any of that stuff, right? So I actually have somebody who helps out with social media, just because that's not an area that I know. It's not an area that I have any expertise in. So I have help with that. But my goal is very clear, is that I want people to understand this field. And I think more broadly than trying to market services, I want people to understand the field so that they can do better longer term. And it may be with us, it may be with somebody else. But if I want somebody, it doesn't matter if they're in North Carolina or California, Michigan or Washington State, if they go have a treatment for their knee arthritis or their torn rotator cuff tendon, I want to make sure that they get the best treatment that they can, no matter where they are. We now know what makes better treatments, which is great. And actually, we've learned a ton over the past even year. And so my hope is to educate. That's why one of the reasons I wrote the book too, is that if people read the book, if consumers and patients read the book, when they go in to look for a treatment, then they'll be able to ask very, intelligent questions of, what are you using? Why are you using it? If you're doing PRP, are you looking at platelet counts on platelet dosing? If you're looking at stem cells, what kind of cells are you looking at? The stem cell story is another one we can dive into if you want, but it's a really fascinating story of really good science that's been kind of misinterpreted in the lay public as well. So,
Thank you. So tell us a bit about Triangle, the setup that you have there. What's the operation look like? What's your kind of day-to-day involvement? What are you offering? Who are you seeing? Just give us a bit of background to your practice.
Well, we see folks from teenagers all the way up to nonagenarians and everywhere in between. I don't do any really traditional medication management. We really focus on people come in, people find us because they're looking for alternatives to steroids, alternatives to surgery. And that's the typical patient we see. Someone who's been through the traditional system. Maybe they have grade 2, grade 3 NEOA. They're not a candidate for surgery, or they don't want it, and they're looking for other alternatives because they've been through, they've had a couple hyaluronic acid injections, maybe with a little bit of improvement, a couple steroid injections a month or two, but nothing longer term. I like to think of myself as focusing on the patients in orthopedic limbo. They have a problem, it limits what they do, but they're not a candidate or not a candidate for, don't want joint replacement surgery, or it's a joint that's not easily replaced, right? We see a lot of thumbs and big toes as well. So those are the typical folks we see, and seeing everyone from young individuals with injuries and sports injuries to professional athletes, to octogenarians and nonagenarians who really just went out and get out and walk with their spouse, their friends, or their dog, and they're having a hard time getting moving again. And they're all really very satisfying to work with. I love working with that whole spectrum of folks. It's very satisfying.
And are there any patients that are not suitable off the top of your head for your kind of approach?
Great question. Folks are coming in on chronic steroids or are having, repeated steroid injections are hard to work with. Those are probably the ones who are kind of in that model and really don't have the time. Also, we need the time. So when folks come in, I like to work with them for a few weeks. We see folks and they may have travel coming up or plans. And a lot of the things we do take time. So if they see us on a Monday and they're leaving on a flight on Friday, usually we'll say, what we have to offer you is probably not going to kick in by Friday. So you might want to go more traditional route with that. But the treatments that we do tend to roll on over a couple of weeks, and it's a gradual improvement. So we like to work with people over those usually days to weeks, not hours to days. So.
In terms of a typical patient consultation itself, what does that look like, and how much of the time is spent on education and expectation management and the kind of the rehab they have to do themselves at home?
I love the initial consultation. To me, I really enjoy those. I tend to use imaging to teach a lot. When people come in, if they have an MRI, we put it up on the screen and we'll go through it. Everybody gets their MRI reports and their X-ray reports. Nobody can understand and sift through the language of those, right? So I just put up the images and we go through the images themselves, because most people can understand an image if you show them what we're looking at. And the other thing I do is I do ultrasound exams on probably 75% of the initial consults I see, because there's a lot of things we can see on ultrasound that you can't see on X-ray or even MRI. And it's really nice to see in real time if somebody has a supraspinatus tear or infraspinatus tear or medial meniscus issue. You can show them those issues and you can show them, and it makes it very concrete for them. So to me, that education of mechanically what's going on is very helpful. And then we talk a lot about how do you kind of ignite that healing process. Talk about nutrition. We talk about some supplements as well. We kind of go through all of that. But that initial consult to me is a really important step to kind of let them help them understand what's going on. A lot of people come in, they've been told, well, I have this and I have some arthritis, but the details of it, they really don't know. And for instance, the shoulder is a great example. Shoulders are complex. They're wonderfully complex, right? People rarely, it seems like, have an isolated glenoid issue or supraspinatus or AC joint. It's an entire unit, and looking at the entire unit, I think, is really helpful and important. So
Thank you.
we also coordinate with a lot of the physical therapists in the area, and there are some really good physical therapists who do very hands-on work. They'll do video filming of mechanics. They'll teach the patients. They'll do this very patient process, which is really wonderful as well.
Now, tell about the book. So the book, Healing Joints and Nerves. I know it's been a bit of a labour of love. It's taken a number of years to put together. So I suppose the question is, what inspired you to write it, and who did you write it for? Was it primarily for patients or for fellow clinicians? Tell us a bit more about the book.
Well, I found myself having a lot of conversations that were cut short in the clinic. People would come in and they'd ask about stem cells, they'd ask about PRP, they'd ask about Regenokine. And the questions they had were fantastic. And I realized that I couldn't answer them in the space of a 10, 20 minute. I needed a longer format. So I just started writing stuff down. I started writing chapters, and I realized it really needed to be a long format book. And I wanted a book that a patient could read, and then they could really understand the entire field of what drives osteoarthritis, what drives neuropathy, and how do I get this better. So it was really written for the patient, although I actually have a lot of clinician colleagues who read it as well and have told me they really like it. It's been a guide for them in teaching their patients as well. So I wonder if there's as many, I think there may be as many clinicians who are reading it as patients at this point, which is great.
And if readers were to take one message from the book, what would you hope that would be?
Our bodies have the capacity to heal. We just need to figure out how to turn on those mechanisms. And that, I think that's it. The mechanisms are there. We just need to figure, and we now know how to turn them on. We just need to turn them on.
And I guess when you write a book, when you invest so much time and energy and effort into something, did that change your own thinking about your own practice? Did you kind of learn anything really key from the research that you did, or anything that was any assumptions that you had that shifted just from the mere act of writing the book?
Absolutely. I think all of the protocols that we do now have really followed on the heels of what the research we did. Now, some of this, it's hard. I can't separate the research we did from the writing, because these are all in kind of lockstep. So we have, research we did in the lab, the clinical work, the reading of all the papers I did to put the book together, and then the writing of it. But, it's amazing how writing can crystallize, and also how an editor can force you to crystallize your thoughts. I had an editor who was very good, and she forced me many times to take out a lot of the unnecessary, excessively technical language in it. What I also realized is that if you can explain something without using lots of acronyms, you probably understand it a whole lot better, right? And that was really an important exercise, because I realized, like a lot of us, we learn to speak in acronyms, and we learn to speak in abbreviations and technical talk. And when I went through the exercise of trying to explain these mechanisms and explain these therapies without excessive technical knowledge, I actually understood them better. So it really helped me to kind of develop that narrative to explain it to patients as well. So it was a great exercise. It wasn't easy. I thought it was going to take me 2 years. It took me almost 7. But I'm pleased with the outcome. It just took a whole lot longer than I thought it was going to take. So
cool. Well, we'll put the details of the book on the bio page, so anybody wants to source themselves a copy, then they should be able to get the information for that. Very happy to help promote that for you. Okay, so thinking now about Triangle as a regenerative medicine practice, it is a business. What are you most proud of from a sort of business perspective in terms of what you've built?
I am most proud that we have followed our vision. I wanted to build a clinic that focused on ways to get people healthier. And also, I'm living outside the insurance world as well. And I really did not, I felt like my hand was forced so many times when I was living within the insurance world of doing things. The first question when patients came in the door was not what is the best way to get your shoulder, knee, hip better, the question was, what does your insurance coverage, what does your insurance policy cover? And I did not like asking that question, but that ended up being the first question I would ask. Well, they cover this hyaluronic acid, they'll cover this steroid injection, maybe they'll cover this nerve burn. I didn't want to do those, and I didn't think that they were helping longer term. So I really love developing protocols and treatments that I think are in the patient's best interest. I love the team that we've assembled. It's, to me, medicine is a team sport, right? A clinic is a team sport, and you're only as good as your crew. And I have a delightful team I work with. And I love the fact that we're continually learning. We measure everything. We measure all of our products. We measure all of our PRPs and our growth factor and our counts and our weight counts and everything. And we're constantly improving that process. And we've actually monitored and improved it even a tremendous amount based on compared to what I was doing even last year and the year before. And my hope is that I will continue that learning journey, even maybe with some publications of things. But I'm proud of the team, and I'm proud of the philosophy of what we're doing. So
amazing. And on that point of learning, what have been the biggest business lessons that you've kind of learned along the way from doing the work that you do?
Biggest business lesson for me was academic success does not translate to clinical success. It really does take direct outreach to patients and those kinds of social media outlets that again I needed somebody to help with, because I didn't understand that field. I really still don't understand, but I have someone who works with it, does a nice job for me. So, but that was my biggest. You can have lots of publications and speaking and in a book and everything else, but if patients don't hear about you, you can run what someone described as a top secret clinic. You don't want to run a top secret clinic where nobody knows about it. And the other thing is word of mouth. Our most powerful. A lot of the patients, actually, probably most of the patients we see, are here because we treated a friend or a family member. And that's really nice to hear, because those endorsements are nice. That means that we're affecting people in a positive way, and they're telling their friends, which is great.
And is there anything that keeps you up at night as a business owner? Is there anything sort of ongoing challenges or bottlenecks that you have to navigate on a day-to-day basis?
I would say very globally, all the business aspects, right? Because I don't have an MBA. I'm not a business person. This is my kind of first foray into running my own small business. So I have to make sure that the rent is paid and the employees are paid. And so I'm kind of in that scenario where I am running, in terms of the team, the clinical protocols, all the business aspects. And I think it's the business aspects that are the biggest challenge for me personally, because that's a new world. The rest of it, the team, approach to things, the clinical protocols, the science behind it, that's a very comfortable space for me. The business part is less comfortable, and that's the part that probably keeps me up more than anything else. I'm learning.
For sure. And I guess as a business owner, you're wearing all the hats and you do a bit of everything. Which is the biggest time drain for you? I mean, there are obviously things that you love doing and you're passionate about in your work, but there must be things that take you away from that. What are those things?
I could use phrases like, doing payroll or that, but, it's kind of all the business aspects. I don't know if it's a time drain. It's just part of the build of the practice. The parts I love are the clinical side and the clinical protocols and how do you tweak the clinical protocol to make it better. Understanding how to get the word out and how to make that match with a viable business plan is probably the biggest challenge. And I wouldn't say it's a time drain. It's just, it's probably an aspect that I underestimated the importance of, and I underestimated how much time it would take. But I would probably say that, the business part of it is the biggest challenge. And that's where I feel like having a good team. I have a great accountant. I have a good social media person. And also I have now staff. I have a physician assistant, Max Mueller, who's just a fantastic PA. And he's doing some outreach as well, which is great. So to me, it's getting about getting the message out about what we do, and more broadly, what patients can do to get themselves better again, even if they don't come to see us. They come to see somebody around the country that they get what they need. So.
Thank you. And if you were starting over tomorrow, would you do anything different with everything that you've learned along the way?
Going back for the business I started last year, or going back 30 years to the career, I guess is the question,
Well, I
right?
guess, I mean, you've made a switch in the field that you're working in. I just wondered if you were going to start a regenerative practice tomorrow with everything that you've learned along the way. Is there anything you would fundamentally change and do from the outset? Or maybe there's nothing. I mean,
Yeah.
sometimes the learning is as important as part of the journey. I just wonder if there's anything that you would do differently.
Yeah, I'd probably pay more attention to the importance of social media earlier on, and have someone join early to really look at that strategy, um, because I think, and that's the part I believe that I underestimated a litlittle bit, the importance of.
Got it. So what does the future hold? Where would you like to be, or the clinic to be, in the next, say, 12 months or so? What are your plans for the clinic?
I think our plans are to continue getting the word out and continue growing. I'd love to partner with, all the local physical therapists. They're doing great work. I love, we're continuing to partner with some of the sports teams as well, and just kind of get the word out. That's my very simple goal. And I'd love to see patients coming in the door who, like they are doing now, or they're coming in looking for a new way of treating their joint, their tendon, their ligament, or their nerve. And to me, it's just a matter of getting that message out and having them understand, and that our growth has been very organic with that. And that's been a nice process, and I'd love to continue seeing that very kind of progressive organic growth too.
And would that be more clinics, or a bigger clinic than you're in, just more staff, being able to treat more patients? What does it kind of look like for you?
Right now, I think it's more of just growing the clinic and the staffing. We have a space that can accommodate a little bit more than what we're doing right now. We are actually just finished hiring up another 2 staff members, actually the past couple of weeks, which is wonderful. So we are growing within our space, which is great. I don't have any immediate plans of additional. I really like to control the quality and the experience of a patient coming through, and to me, it's a very big step to open up a second site where you're not physically present as much. So I really enjoy very much that hands-on approach, because I can monitor and make sure the quality of the experience is great. To me, it's like running a nice restaurant, right? I want people to have a really great experience from the moment they walk in to the moment they leave. And I feel like, maybe this is because in college and medical school, I waited tables at restaurants, but I feel like their model is a really good model of the patient experience, more so than a traditional medical model where patients come in and they're going to get what they're offered, and they're only going to be offered a few things, and that might or might not be what's best for them. And I really love that service-oriented model of a restaurant, really, as much as anything.
And final question on closing. If you could change one thing about modern healthcare, what would it be? Slightly philosophical question, but I thought a good one to end on.
I would love to have this paradigm shift that we're talking about shift more quickly. And I think it's needed. I think it's in all of our best interests. These shifts happen very, very slowly, obviously, and old paradigms die very slowly. But I would love to see this kind of way of keeping joints and nerves healthy. I'd love to see those mechanisms and those techniques be employed faster than they are.
With that, Thomas, I'd love to thank you so much for joining me today. I've really enjoyed the conversation. Thank you for telling us about your practice, the different things that you can offer the patients, giving us a real understanding of regenerative medicine, what it is, what it isn't, some of the misconceptions, and just sharing a little bit about behind the scenes of the practice and what you're aiming to achieve. It's been a real delight, so thank you so much.
Andrew, thank you so much. Really appreciate you having me on. It's a delight to talk.